This is Dr. Somnath Mukhopadhay, DM Cardiology, passed in the year of 2018, presently practicing interventional cardiology in Nightingale Hospital, Kolkata and Salt Lake AMRI, Kolkata. Our today's topic of discussion is latest update in hypertension. To introduce this topic, as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to CVD, cardiovascular disease, which affects 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factor for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. So there are several points. First is, in India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people of 51% of the men and 41% of women with hypertension were unaware of their conditions. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. This is a WHO document published in Lancet 2021. International Society of Hypertension, ISH, has released the ISH 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards, a standard of care for low resource setting. The AHA-SEC has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low-risk adults, no ASCVD or 10-year CVD risk less than 10% with stage 1 hypertension, blood pressure 130 to 140 and 80 to 89 diastolic. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Next point is ARDS, acute respiratory distress syndrome, is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Next point is lowering systolic blood pressure targets down to the 110 to less than 130 millimeter mercury range substantially reduced CVDs, severe adverse events, in the STEP randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged 60 to 80 years in China, the intensive target trimmed 26% of the composite CVDs. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold of 130 to 150 millimeter of mercury. Now, next is with regard to prognostic value of ambulatory blood pressure monitoring, ABPM, and nighttime blood pressure monitoring. The 2018 European guideline on the management of arterial hypertension recommended that the diagnosis of hypertension should not only be depend on office BP measurement, but also an out-of-office BP measurement such as ambulatory blood pressure monitoring or home blood pressure monitoring are to be included in the definition and in the diagnosis. 24-hour and nighttime BP measurements were associated with greater risk of mortality and a composite of severe outcome. Thus, they may be considered as the most relevant measurement for estimating CV risk. For every 20 by 10 millimeter mercury, that is systolic 20, diastolic 10, 20 by 10 millimeter mercury increment of blood pressure measurement at night, the risk of mortality increased by 23%. And the risk of cardiovascular event increases by 36%. That is significant enough. Most patient, our next point of discussion is most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. 2018 European guidelines equally recommended 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and blood pressure control. Therefore, the 2018 European guideline recommended that, especially in the context of lower blood pressure targets, to start antihypertensive therapy with an initial dual fixed dose combination. So, this is the recommendation of the fixed dose combination of ACE inhibitor, ARB plus CCB or diuretics. This is the combination. So, that is the very relevant thing, that you can use combination drugs from initiation. Since early July, next point of discussion is, since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency cancer to be carcinogenic in human, and if 1 lakh patients would have received NDMA contaminated valsartan from a site, actually name is Zhejiang Huahai manufacturing site, where the highest levels of contaminants are found. Every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. That is not at all insignificant. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose of over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visit of 6%. Next, and the last discussion for today, is the HYGEA study, which represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoint, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CVDs reduction. The largest study included a total of 19,000 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how BP is different during sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment, and HYGEA studies actually supports the nighttime BP reduction by whenever it is used with ABPM or HBPM monitoring, usually ABPM monitoring, not HBPM monitoring. That is an advantage over nowadays. Patients are asking about higher nighttime and daytime BP measurements, and whether ABPM is better than HBPM or HBPM is better than ABPM. In this study, HYGEA study, and the recent trials with the recent documents, those are telling that nighttime BP reduction is very important thing to reduce CV events, and nighttime BP is particularly properly measured by ABPM. And though there are some fallacies of ABPM, during ABPM patient cannot sleep properly, and there may be a chance of more sympathetic activity to increase blood pressure. After all these arguments, till now, to record nighttime blood pressure, ABPM is the better technique. The latest update in hypertension, to conclude, first is the Indian scenario. You have to treat properly, you have to treat more. Second important thing is lower the BP, lower the systolic BP, then chance of CV events are less. Third is the points regarding ARDS, blood pressure monitoring properly, and metoprolol can reduce lung inflammation. So with antihypertensive, you can reduce inflammation also. Third important thing is the issue of HBPM and ABPM, that is out of office blood pressure monitoring has come forth in 2018 European guideline. Now, next important thing, so we have discussed that recommendations of recent sartans having NDMA, that is carcinogenic. And the last thing is nighttime BP measurement, where if nighttime BP can be reduced, we can lower the CV events. So That's all for today's discussion. That's all for the latest update and latest update in hypertension. Thank you. Thank you for your patient hearing.